Any questions from the previous class? Because it was too much to assimilate for some of us, because designing a program and facilitation, it's only like comfortable for trainers who are already doing it. But for all others, I think it must have been very challenging. Dr. Birender, how did you find it? Were you okay?
Yeah, definitely. And the thing that I have carried forward just as a feedback was the concept of adult learning, which was bringing from the unconscious incompetence to a conscious incompetence. So that was the key takeaway, one of the key takeaways. Thank you very much.
And I think one realization that if we want instant result, it won't happen. It will take time for people to change. And if you are able to tolerate that, and if you're able to, preserve, you have perseverance on that front, I think then you can expect changes. So Ramya, Bhanurekha, Pooja, Namrata, all of you must be already in training. So did you find the concept useful? Because you're already trainers. So did it add any value to your trainings? Even Ritika, I think even you are training.
Yeah, definitely, ma'am. It has given a lot of insight regarding like how to inculcate an adult communication into the training. That was really helpful, and thank you so much, ma'am.
Wonderful. So Dr. Dipti, you found it quite a bit, quite heavy.
This week was very heavy for me.
I know.
I have been trying in the sense, like now that I'm communicating with my students, I recall all the points that we have discussed. And a whole range of learners from beginner MBBS to mid-level MBBS to final MBBS to interns to postgraduate SRs, every range is there. So I follow those basic tenets of learning. So definitely I feel that I'm better off than what I used to be, yes. But I'm still struggling a little because this is my cup of tea, number one, and number two, because of my circumstances.
I completely understand. One, because we haven't done teaching training in a formal way. You may be having a lot of clinical experience, but when it comes to teaching a subject in a formal way, it's a very different thing. And of course, once you start implementing it, then you'll be able to, recollect what all can fit where all. That will make your program, more successful. But it's a slow process. It's like coming out of your comfort zone.
I feel that, yes, I feel that I'm collecting a lot of points and they're all marked up.
Yeah.
And as I go by, and maybe those points will fit in the correct place. This is what I'm hoping.
Yeah. So it's something for us from unconscious competence, we have moved on to conscious competence now. We are trying to implement it. So from unconscious competence to conscious competence to conscious effort you are making. That's the toughest phase. But once you're able to use this in your regular teaching, slowly you will see that you will actually, this will become part of your way of trainings and teaching and facilitating the program. So it's a matter of practice, that's all. And you have a lot of students, and on daily basis you are talking to them and training them, teaching them. So I'm sure you will be able to implement it very swiftly, and very soon you will see that there's a change in your way of pedagogies of training your students, teaching your students. So Namrata,
Dr. Indu,
what is your feedback?
I'm sorry, Dr. Indu, this is also helpful in day-to-day management of the hospital, because sometimes training mostly is very, in a very formal setup usually, but there's a lot of training happening, be it in clinical or managerial aspects while we are working.
Yeah.
So the Socrates also stayed in my mind that I can't teach you something like that, but only make you think.
Absolutely.
Yeah, I can make you think.
I think it's not like that. It has to be a formal setup for you to facilitate. What you're looking for is, making people aware, changing themselves, skill building, personal development, even feedback that you want to give them.
It is helping in the problem solving as well. How to approach. So while we resolve a challenge or an opportunity.
Yeah.
I mean, there is this training element there also.
And also, the background that, okay, people will take time to change. And then they will only understand when we are able to engage them, or they are only going to participate if they are able to, get involved. That learning itself is a big learning to, help people, get engaged and then bring change in their behavior. Very clear. So, Dr.
In
Gaurav,
fact, the video on empathy, Doctor, the video on empathy, I have planned to play it Monday morning.
Okay.
In the first thing in the meeting, we are going to talk about, I've already struck the concept of empathy and sympathy, which had a discussion.
Yeah.
Nothing like that video. Thank you for sharing.
Absolutely.
And
I think that's a very...
look at it once a month. I think definitely that video I'm going to play in any meeting.
Sure.
Yeah. Thank you.
I think that's a wonderful idea. Excellent. Yeah.
Ma'am, I would just like to add that I agree totally with Dr. Birendra that the formal setup and informal setup, this also helps us in engaging our team, be it us seniors or be it us team members. So interacting, getting the work done, and the art of getting work done, art of coordinating work with them. So
Absolutely.
This is helping us there also.
Absolutely. I think our whole approach will change once we'll have this realization that if you want to bring change, you have to give time, you have to facilitate, you have to engage them, you have to motivate them, and all those techniques are nothing but we are improving in our way of handling people. That's it. Yeah.
It's also part of personal interaction also. In personal interaction also, it also plays a role.
So with your life partners and with your kids also, okay, I have a different learning style. And I send that document on your personal representation system. I don't know how many of you really worked on it. Did you try? Did anybody try that? You will get to know what works for you. Is it auditory? Is it
yes.
visual? Personal. I send that link. You must attempt to do that. You will find. So any other point anybody wants to bring forth? Dr. Gaurav, Monica, anybody else?
Yeah. Yes, ma'am. So for me currently, I'm not working. In the clinical setup currently.
Yeah.
But as I told you before, I'm working with Maro. It's an edutech platform. So there, so I'm in this position where sometimes I have to give quality reviews and feedbacks to my juniors. So that's sometimes critical. You cannot be too harsh. You cannot be too smooth. I think the nuances of what we are learning subconsciously, as Dr. Birendra sir was saying, we have implemented this when we are giving feedbacks, we are giving reviews as well. It's just that doesn't stop only with communications, with regards to, the patient management. I think indirectly somewhere or other, it has hit our subconscious mind and we have started practicing it and we're slowly able to notice a change. So I can see that when I do my weekly reviews with my juniors, so I get to see that usually after the call is over, so sometimes I do get some feedback from them. I ensure I get the feedback from them. But, when there were nuances and instances when they said you could have been a little polite, or there were nuances and instances when they said you could have told it this way. My boss is also on the call, so she tells me, you could have done it that way. You were a little harsh on him or her today. Yeah. So I see those instances have come down and they have also started implementing this. So most of the times, people are resistant to feedback, but I think if we modulate, if we present it in the right way, I'm sure that they are also ready to receive it and I'm able to see the changes with time, at least in my field. Currently, since I'm working with the edutech platform. So that's one thing. And that is what prompted me to pen down that post as well in LinkedIn. So it has hit us somewhere, and I'm sure we continue to practice and read more about this and keep in touch.
Absolutely. There's a very beautiful book called 1 Minute Manager. I don't know how many of you have read it. It's I should have its PDF. I look for it in my drive. If I have it, I'll definitely share with all of you. Otherwise, it's a free PDF available and it can be downloaded. It's a beautiful book on how do you handle your team. Because most of you are managing people, most of you are managing your team. And if you know what is the right way of managing your team, I think most of your struggle will come down. And trust me, I implement that to almost every bit of it because I really appreciate what the author has written. He's a seasoned author who has written a lot of books on organizational behavior. And this is a gist of everything. And it says, I mean, if you can implement this, it's a 4 steps. And then if you implement, you can win anybody. You can get anybody on your side. It's a beautiful book. I look for it in Day Drive. And what Dr. Gaurang is saying, like giving feedback. The feedback we give, the way we manage is all very outdated, it's old fashioned. Today, feedback is very different because we are dealing with the younger generation and people are coming from different backgrounds. Even the Maslow's theory does not fit into them. Actually, Maslow's theory has been revised for millennials. We should know this. And that's why all basic needs and all other needs are not working for them. You really need to strike at their self-actualization need and self-esteem and social needs. If you really need to do that. What I'm trying to say here is, has somebody entered from two devices at a time because there's an echo?
Yes, madam, I was trying to join. Now I have switched off one.
Okay, so I can't see your video. Are you there? Difficult
yes,
to have
I'm just joining. Yeah, joining back.
Okay, no problem. So, we are actually focusing on the trainers program, and what we are discussing is actually a leadership management program. But there's a lot to it and very beautiful content to implement right as it is, and it will really bring a change in your way of handling your team and your people around you. And even on the family front, you will find it beneficial. So I'll not now go into it, and we'll come back to the topic that we are here to discuss, and that is understanding patients' expectations. I'm going to use a lot of pedagogies to show you in this session. That's one thing. So keep an eye on the different pedagogies that I will be demonstrating. So again, from this session onwards, we are going to talk a clinical topic. But as I said, we need to focus on the clinical topic and as well as the pedagogies that we are going to learn. And two of you are going to present your pedagogy. So today, Dr. Shashikala was also supposed to be here, but she has a marriage in the family, so she hasn't joined. She may not be joining also, but we'll have presentation by Pooja, and then Dr. Shashikala will be maybe presenting in the future sessions. But Pooja's presentation will be after I finish this topic. So topic of today's discussion is patients' expectations. Understanding patient expectation. How many of us really care to sit and think of patients' expectations? Really, in real sense. Especially those who are in healthcare, I want to ask them. Do we ever care in what areas? We really, patients, what do they expect and what are we doing with them? Are we really giving them the desired service? Yes, I can see Dr. Ila's hand. Give me a second, Dr. Ila, I come to you. Okay. Monica says, yes, we do it. Okay.
I think partially, yes. Definitely not 100%.
I would say it's a more honest answer. It's a more honest answer. Dr. Ila, because you are in quality, so I'm sure you must be really looking at everything from the patient's perspective. And that's the way quality people should be doing. But the problem is when it comes to implementing and the healthcare providers who are handling the patient, are they able to see that? Are they really able to understand their expectations and how it affects the feedback, it affects the patient satisfaction, it even affects the outcome of our services. You may give the best of services, but if your overall conduct and overall handling is not as per the patient's expectation, most of the times they go back disappointed. A lot of time we go for a wedding, there's a lot of food, buffet, everything is there, but the host is not very warm, host is not welcoming, host is not looking at things from our point of view. You come back unhappy. What is this? Yes, Dr. Ila, you have a point to say. Please go ahead.
Yeah, so what happens, I just want to share here something like in our hospital, we have something called as concept called patient care committee. So what do we do in that? We have that committee has got in charges or the working in charges from most of the clinical areas. So immediately when we start our day, like general duty is 10 to 6. So when we start our day, we have in our hospital, there is a prayer system. So 10 o'clock, there is a prayer. So immediately after the prayer, which gets over by 10:20, we start our meeting at 10:20. One place has been decided. So all those working in charges has to meet at that one place for 15-20 minutes. Their meeting is being kept every day. And there is one coordinator of that meeting who is the floor facilitator who meets the patient every day. So that coordinator or the floor facilitator has all the patients related feedback, and patient complaints or any concerns or anything related, they have all the information. So they share about it, and all those working in charges get to know about it. So it is all about updating our side, that what are the patient's expectation, what are patient complaints, because many of the times it's like just handing over, taking over, because it doesn't get passed through. The second shift person doesn't know about it. So that's why we make more mistakes rather than, correcting it. So this concept, it's been going on since more than 3 years now in our hospital. It's working fantastic.
Wow.
So we are actually prepared before only, and patient feels that we are attending them personally. It's a personal attention that patient gets. Any patient there, and so many feedbacks which we have received, and so many improvements because of these committee meetings.
Absolutely.
So that is how I just wanted to share.
That's a wonderful, effort. I think this is what is required in every hospital. Now, of course, we are getting used to the idea of patient experience officer or patient care coordinators. I mean, they're supposed to be actually, liaising between the patient and the healthcare facility so that their needs are personally, addressed and are met well. This is what we are, supposed to be now moving towards. Of course, I'm not talking about the government setup where we are overwhelmed with the numbers, but there also we need to see how can we ease out things for them. So let me do a small activity with you, and you can call it as process mapping. You can also call it as visualization. So I'm introducing two, pedagogies at the same time. I hope all of you have a copy and a pen with you. Yeah, keep it ready. So I'm going to take you on a tour of your hospital, and just try to note down the key points. For example, I'll be taking to a different places, and you need to just think of what were your expectations and were they met or not. So maybe a keyword you will be writing, because I don't expect you to write very long, passages, but just the keyword. So imagine that I'm taking you to your hospital, and you are not employee of that hospital. I know all of you are not working in healthcare, but a lot of you are working in healthcare. But those who are working in healthcare, please imagine that hospital, you don't belong to that hospital. You are not an employee of that hospital. Now imagine yourself entering the hospital gate for an appointment with your doctor. That's the activity we are doing. See yourself parking your car. You're not a hospital employee, and the parking person does not know you. So what do you expect from the parking fellow? And check were your expectations met. Especially if you didn't know the parking fellow and if there was no parking place. Okay. Now see yourself going towards reception to confirm your appointment. Of course, in the government setup, we don't have any formal way of going and checking if my appointment is confirmed. But in private setup, we do have system where you go and ask, okay, I have an appointment and I'm here for the consultation. So see yourself at the reception of the hospital and checking for the availability of doctor and confirming your appointment. Your appointment is confirmed and you have been asked to wait, as there are a couple of patients before you. It will take almost like 45 minutes before you can see your doctor. Again, check what expectations you have from the receptionist and what they met. You look at the waiting area and look for the place to sit. You know your hospital setup, you know your hospital sitting arrangement. So are you happy and comfortable waiting? And are you happy about the waiting area? Is there enough space to sit? Are there people standing? Do you have facility for water and toilet, ventilation, cleanliness? So your term comes for the consultation. You had a long wait. You were said 45 minutes, but it has taken almost like 1 hour. Are you okay with the waiting time? You get into your doctor's chamber. And if you're not working in the hospital, naturally, you don't know the doctor personally. What would have been your expectation from your doctor? check the quality of your interaction with your doctor. Were your expectations met? Note down. So your doctor has asked for some blood work. You need to go to the lab. See yourself in the lab. You all know your hospital's lab, where it is situated, how it looks, how comfortable it is, how much of waiting area it has to accommodate people who are coming for the blood work. Check the experience and interaction with the lab technician or the person at the registration. Again, check your expectations. Were your expectations met or not? After the lab work, you go to the hospital pharmacy to get your medicines. If it's a government setup, naturally it's a free pharmacy. But if it's a private setup, of course, it's a paid pharmacy. Again, try to focus on the expectations that you would have from the person who's dispensing the medicines. Were they met? Did you get your medicines easily? Did they explain you about the medicines and answered your questions? So whatever expectations you had from the chemist or pharmacist or the person who is dispensing the medicine, were they met or not? Go back to your parking place, sit in the car, and look at the whole experience that you had in the last couple of hours. Are you satisfied? Share your experience. We'll keep it very brief, but I want a couple of you to respond if there's something very interesting that you want to share. Yeah.
Yeah, like if I may.
Yes, Dr. Gaurav. Yeah.
Parking area, basically I would expect the security guard there or the parking in charge there to guide me on alternatives to parking.
Yeah.
The parking slots are full, at least he helps me to, let me know where I can comfortably park so that both the car is safe and I'm not at tension. Yeah, but definitely I would expect that the hospital cater to the crowd and probably increase the parking space. One example is I've had experience of both. I did from a GH, so my MBBS was from a government hospital, and at the same time I have this experience of handling patients and also being a patient at MGM Healthcare Chennai. So I've seen how the basement parking, how the three-tier parking system works there, how patients feel comfortable and not here. So that's something that I would want to. Receptionist, yeah. My first question is, if she tells me 45 minutes, I'd like to ask her, like, why is a 45-minute delay? Because she's given me a slot, she's given me a time. So why is it that? What's the reason why there's 45-minute delay? So this is a usual question which people have.
Yeah.
So I think expect as a person with my character, even before I raise this question, I would have expected the receptionist to probably not apologize, but probably let me know in a comfortable way that we're sorry, we got busy, we had some emergency patient or something. Because as a consumer here, I feel it's my right to know. Because I've taken the effort to know book an appointment and come, and it's important she lets me know. With regards to waiting rooms, most of the government hospitals are very ready for, there's very much nasty corridor to be specific, and lack of chairs. People I've seen, especially medicine and gynec, to be specific, there are patients who literally sit down. They cannot stand, especially when they're old. So if it's dirty, crowded, it will be a little bit intimidating, off-putting. With regards to doctors, yeah, I guess when I visit him after a delay of 1 hour, and and it's crossing the specified time by the receptionist, at least I would want him to greet me with a warm smile rather than saying, yeah, come sit. Maybe I would just want a smile from him. I think most of the time the smile can compensate for most of the wrongdoings, at least what I feel. So with
did you
regards
get
to
this smile? Did you get this smile?
no, in my hospital, yes, but in MGM, no. So as an experience, I'm saying, so no, one side yes, one side no. So with regards to lab, it's always a problem. Most of the times labs are situated, at least from my experience, that they're far off from the main OPD or the hospital. So there has to be appropriate direction marks, or there should be a roadmap asking patients where to go, and it should promptly come from the nurse or the person who's actually going to dispense the requisition forms, or the interns, or whoever is the attending physician. Then coming on, one specific bad example is with regards to sample collection area, especially when it's a urinary sample collection, the areas are really not neat. Most of the time they're ill maintained. They're not precisely well maintained. So that would be off-putting. Lastly, pharmacy, most of the times the pharmacy, they have this pre-printed uh, morning, afternoon, dinner. So the pharmacist just puts 101, 201, 301, and it's like self-explanatory. But then patients always have this doubt of before food, after food. That's not specified, or most of the times, at least if it's an illiterate patient, it's like white tablet, yellow tablet, many safed ka tablet. There are so many safed tablets. So take this extra effort to explain, especially if they're a geriatric patient without an attending person, a pillion patient or a patient carer. So I think these would pretty much be my expectations. And lastly, when I walk off the parking, I want my things to be safe. So that would always be there.
So I think I know, Namrata, you want to add something. Just give me a second to come back to you. And I would request all of you to keep it very brief, because we are already short of time and you have a lot of experience to share. I completely agree. I think this must have given you some idea what patients go through when they come to our hospital. We just simply treat them like, okay, you have come for consultation, so it's your problem. You will have to wait. If you have to go for blood work and if there's crowd at the lab, you will have to wait. Collecting report, like whatever our format is, you will get the report only on that specified day. There is no, accommodation or deviation from what we are doing. I remember I had gone for an assessment for RML hospital recently before I came to US. And, at the lab collection center, at number of places they put this A4 size, message. You will get your reports after 1 week in the OPD from wherever you have come. So kindly don't come and ask us for the report. Imagine if I'm getting my blood work today, after 1 week, how much of relevance will it really have, unless it's a kind of a regular kind of a blood work. So not even realizing what is the patient's requirement, and if I'm giving a blanket kind of a order, it's not going to help in any way. And I'm sure this you must be seeing day in, day out at various settings. So the activity that we have done was give you an idea of how patients go through at these places on daily basis. Second, when you were there, I think you could see how sometimes painful it is. Suppose if your car is not in place, or it's, or the doctor is not there and you're waiting, and you are then later said that, no, sorry, doctor is not able to make it because he or she is busy. Or when you stand in the queue in the pharmacy and it's a government setup, it's a free medicine, and when your turn comes in and you are said, sorry, this medicine is not available. I've seen this happening right in front of me. He literally threw the medicines. He said, what is this? I waited for 1 hour for the medicine, and you're giving me this multivitamins. I require this medicine. This is most important for me. And he said, don't give me this also, keep it with you. But see, we don't understand, why should the patient wait for so long? This again happened at RMN. I said, how will the patient know in the beginning that these medicines are available or not? And they had 8-10 pharmacy interns in one of the counters. I said, why can't you post them at different place? They would have the list of medicines available, and they can immediately tell that these medicines are not available or this is available. So before they go and stand in the queue, they can be guided. If you think out of the box, you can find solutions to the problems. The third pedagogy that I have introduce to you is called design thinking. Have you heard of design thinking? Has anybody heard of design thinking? No. And I completely understand, because design thinking is a new concept being used by most of the corporates who are into consumer, facilities or consumer products. Amazon, Zomato, Swiggy, Uber, Ola, all these have been designed with the concept of design thinking. I'll be talking about it in the end. But just with one visit to your hospital, that also imaginary visit, sitting right in the place where you are, you now know where all the problems lie and what are the patient's expectations. And tell me, whatever you expected, was that something too much? No. But then, did you get that? And when you don't get it, definitely you are, very unhappy. Whatever, even if you have paid for the service, or even if you have, you got the treatment, but then somewhere the experience has not been really, really very good. And that was the idea that I wanted to share with you. So I think I can see two hands. One is Namrata's and second is Pooja. I would request both of you to keep it very, very brief so that we can move on with the next point. So Namrata, please go ahead. Yeah.
Ma'am, I would just like to add one point, like where the expectation comes, being from the patient interaction team and everything, I feel giving a personalized attention, expectation, like even if the security guard is there, good morning, sir, like the greeting and acknowledging the person, for the receptionist to acknowledge the person, for the coordinator of doctor to acknowledge. So this is one of the major expectation as a patient I would have. And even if I get even from 50% of the people whom I have interacted in hospital, so that is the
absolutely.
I mean the thing.
I completely. So how small is the expectation that people please look at me, smile, say good morning, welcome me, so that we can, and that doesn't take time, but that requires mindset. We see this happening at hotels. If you go to 5-star hotels, they'll immediately tell you this. Or when you go to any good place where people are very courteous, you get to see this behavior. Healthcare thinks that this is not the place for these courtesies and this kind of behavior, because in healthcare, we are serving you. You are not obliging us by coming. So this comes from that mindset, and that's where we are struggling. Yeah, Pooja, you have something to say. Go ahead. Yeah.
Actually, this exercise I cannot practice on my own. So I am planning to do this in the next session that I am doing, because that is really interesting, because I can actually understand the way Dr. Gaurav was explaining this entire thing. No, because if we are into a system, we can definitely see it from the other side. No, that what that manner. So utna to idea nahi hai us cheez ka. But yes, the query that I had was like what we discussed initially when we started. No, so from the training perspective, I thought of like we are talking about creative visualization, but jaise humne jab discuss kiya towards the end for design thinking, so I was a bit confused in that. That is why I just raised it.
So design thinking is something based on imagination, or your visual visit or imaginary visit. But then how you are going to use it, I'll explain you thoroughly at the end. And that's a beautiful concept, and you're going to really enjoy it, and it's going to really add to your kitty. I think we have a lot of questions. I think Dr. Dipti and Monica also wishes to say something. If it is very short, if you can please keep it very short and specific, I'll be very happy, so that we can start with the discussion and other points. Yes, Dr. Dipti, please go ahead. Yeah.
I have just two queries.
Sure.
If I start applying this smiling, I saw today in my hospital, I saw a very poor, almost destitute woman walking in with 3 children. There were 4. And her husband is admitted in the surgical ward, which is outside my office. So the guard is stopping her. You can't take with 4 children, you can't go inside. It's all infected area.
Yeah.
Now I can see that woman, as a routine, I won't bother to observe that probably. But I can understand that woman, husband is admitted in surgical emergency. She can't leave behind her 3 kids. Now, how will the hospital handle it? And if I am a manager, how will I work out a provision for that? Number one. Number two, probably everybody is working in good hospitals, corporate one, good people. My hospital serves the poorest of the poor.
Yes.
They are poorer than even the guard who is standing at the gate. That social hierarchy and that mindset comes in place.
Yeah. Yeah.
How to be polite to somebody who is much lower to you in a hierarchical place, who's almost destitute, total shabby clothes, dirty clothes, and 3 whining children, and she's something like a migrant or somebody. So
Dr. Dipti, you have asked actually 3 points, not 2. And I'm going to answer all 3 because they are very pertinent. If I'm not able to satisfy, then this training is useless. It's not of any help. One, that there's a lady coming with 3 children and I need to tell her that you can't take your kids inside because it's full of infection and I don't want your children to be exposed. So the thing is, if I don't have to allow, I don't have to allow. But the thing is, how do I interact with that patient or that lady? That's very important. If I can just make her understand, see, I can allow you to go in, but then your kids' safety, you have to ensure. Because you can't leave them alone. Suppose if something goes wrong, then you will be in trouble. But if you want to go in, I can't allow your kids to go in because there is a lot of risk for infection to your kids. Now, what I say, if I'm saying like this, or if I say, बहन जी आप अंदर नहीं जा सकते, मैंने आपको एक बारी समझा दिया ना, छोटे छोटे बच्चे हैं आपके, इनको इन्फेक्शन हो जाएगा, अंदर बीमारी हो जाएगी, आप उठा के ले आते हो बच्चों को साथ में, क्योंकि तरीका है, आप हॉस्पिटल में आए हो कि घूमने आए हो पार्क में?
Luckily the staff nurse spoke in the former manner.
That's all. See, we all have to learn to behave. I'm not saying compromise the protocols. I am not saying. But the thing is, am I mindful of my language? Am I mindful of my behavior with the patient? That's what I'm trying to focus. I know we are pressurized under government setup, but that does not give me the right to be rude and intimidating and badtameez with the patient. We become, absolutely, what do I say? Very arrogant in our approach. And we start dictating terms on. I'm not saying allow. I'm not asking you to. So we'll be talking about assertion where you say what you want to say, but your language remains very, to the point. You don't lose control on your language or tone of voice or your body language. We'll be talking about it at length in one of these sessions. That is one point that is said. Second was about the guard who is there. See, sensitization of every healthcare provider to behave well is very important. In AIMS, in RP Center, I was made to do around 20 programs just for the security guard and the housekeeping staff. And I got the feedback, there was a change in their behavior. Just one session where they just need to see, even if you are a guard, you are a very important part of the team and your behavior makes a lot of impact on the patient. So it's the vision of the head of the organization who sees the importance of these things. Third, when you talk about smiling or talking nicely, I repeatedly say it's not a matter of time. It's a matter of mindset. Immediately, if somebody known to me comes in front of me, I would smile and talk and also behave well. So very smartly, I am selective in my mind with whom I have to give what behavior. जैसे मैं हिंदी में कहती हूँ कि हम मुंह देख के थप्पड़ मारते हैं. सामने वाला व्यक्ति हमें लगता है कि इसको रिस्पेक्टफुली बात करनी है, हम प्यार से बात करते हैं. जो हमें लगता है कि इसकी हम बेइज्जती कर सकते हैं, उसकी हम बेइज्जती करके बात करते हैं. So we have to be mindful in healthcare. People are not coming out of choice. And nobody likes to be poor. Nobody likes to be destitute. I think we have to always be thankful to Almighty to have put us where we are today. And be thankful. I hope that answers your questions. Thank you so much. Yeah, Monica, you have something to say. Go ahead, please.
Yeah, ma'am. My questions are related to the cost of treatment and the medicines part, basically. Like once the patient goes to the pharmacy, most of the times the pharmacy people, they do not tell them that at what cost they are going to get it in the market outside.
Yeah.
So generally, whether it is a poor patient or whether it is generally in government, they are supplying free medicines. But for the private sector, there is a difference in cost. And most of the times, like I've myself also seen, there is a lot of difference in the cost of the medicines. So that is a very important point, what I have seen in my experience.
So what you have observed, if you are working with a hospital or if you have your own setup, then I think if you can see how can I ease out for the patient, how can I make it more transparent and convenient for the patient? Can I have, a price which is actually more like, what is available everywhere? competitive price, or can I even go further by giving them further discount so that they don't have to go anywhere and they're happy that, okay, this place is offering me as good discount as any other place. Actually, we lose unnecessary business just because of this, because we have overpriced everything. But I'll not get into that because that's not what we are talking here. My idea of taking you for that trip was to understand patients' expectations. And most of these expectations are not unrealistic or over demanding. They are real. Only thing is, we don't look at it from the patient's point of view. We are in healthcare, we can get things improvised. We go to reception, we don't even have to get the registration done. We just pick up one of the blank registration and go to the doctor's room. Not even that. If I know Dr. Dipti, I will not care to do anything. I'll just get into her chamber. I'll say, Doctor, main dikhane ke liye aayi hu. She'll pick out her OPD slip and she'll write my name, examine me, and write her medicine and give me, because I know Dr. Dipti. But all patients cannot go to any doctor's room and just, they have to stand in queue for hours together to get that one white paper of OPD slip, which takes almost like, especially in Pant, I have seen people coming in the JB Pant hospital, people standing in the queue right at 6 o'clock, 4 o'clock in the morning. 4 o'clock in the morning. I was shocked to see. Imagine, that's the plight in government sector. And in private, of course, you have to pay and get the appointment. I know we can't change the system. Can I make things better for them? But those who are in management, for them, I'm going to give you design thinking as a tool, which will help you improve these services within your limited resources. But we'll talk about that later. So have you read those case studies? Yes, Dr. Birendra, you have something to say. Go ahead.
I just want to add one thing.
Sure.
Is that, the entire healthcare system, be it the education or be it the treatment or be it the research, is for the patients.
Yeah.
And there is a disconnectedness. There is a disconnectedness that has come in us, that our jobs, our careers, our lives are different, and you need me or us.
Yes.
But it's actually we also equally need.
Absolutely. I think once we will have that approach change from doctor-patient or doctor-centered approach to patient-centered approach, things will completely change. So very quickly, absolutely, I completely agree. So very quickly, if we could have a look at one of the case studies, the first one. Have you read? Have you all read? So
yes,
can somebody?
But I couldn't find where the case studies are. I posted a question.
I sent you the course material. Once when I send the confirmation email, I normally send the course material.
Okay, it was in that. Okay, I thought it is some fresh mail that you have sent. I'm so sorry.
No, it is in that. It's okay. I'm going to share the screen with all of you and you can read it. But we'll just spend 2 minutes reading it and then we'll have discussion around it. Already we have had good discussion. So I don't want to spend more time on it. Give me 1 second. Okay. Okay, so this is the case study. I hope all of you can see it.
Yes, we can. Yeah.
So can we have 2-3 people reading it one by one so that nobody has to read it complete? Anybody who volunteers? Sure. Yes, please. Yeah. So tell me when you're tired, we can ask somebody else to read.
Right after dinner, Abdul Rahman clutched his chest and told his wife Zeenat that he thought he had a heart attack. Zeenat wasted no time getting Abdul and their 16-year-old daughter Katrina into the care and raced to a nearby hospital. Although the ER was quite busy, Abdul was placed into a room immediately and attended by Dr. Raghavan and the nurses on duty. After taking history, the team checked his vital signs, including pulse rate, BP, breathing rate, temperature, and auscultation. All preliminary tests were normal, and Abdul noted that his chest pain had also diminished. "I'll be back in a while," Dr. Raghavan said. The nurses also left the room, going outside to take orders from Dr. Raghavan. Zeenat held Abdul's hand while he was still lying on the examination table. Katrina began to cry. "Dad, this is scaring me so much. I don't know what I would do if anything happened to you." "I'll be fine," Abdul replied. "I'm feeling much better already. I bet they'll let us go home very soon." 2 or 3 times during the next hour, one of the nurses looked into the room, scanned various instruments, and left. Another hour passed, then another. "I think they forgot you were here," Zeenat said. They know you're fine, or the doctor would be checking on you. I'll find someone and see if they're finished with you now. I'm getting impatient. Just sitting here with nothing being done and no one's telling us what's going on. Zeenath went to the large circular desk in the middle of the room and asked a nurse if it was all right for Abdul to leave since they had been in the room most of the time alone for quite some time. I'll ask Dr. Raghavan, a nurse said. It may be a few minutes. He's with another patient. We might as well leave. He's feeling better and there doesn't seem to be a reason to sit around here, said Zeenath. When the nurse saw Dr. Raghavan, she asked him, Doctor, Rahman's wife just said that they want to go as nothing is being done, so he must be fine. She thinks that they should leave. That's ridiculous, said Dr. Raghavan, almost shouting. So she's bored and wants to go home? Tell that female that this isn't about her and her comfort. It's about the patient. Tell her no. I'm not releasing the patient until we've completed our monitoring and we are certain that he's not at risk. Katrina had wandered outside of the exam room moments earlier and couldn't help but hear this entire conversation through the conference room door. She went back to the room and said, Mom, it sounds like the doctor's pretty mad at you. Are you kidding, Zeenath? What for? He thinks you want Dad to go home just because you are tired of sitting here and that you don't seem to care whether Dad is well or not. He told a nurse that they were still monitoring him. They're still monitoring him? How do I know? No one has spoken to us for us. They just left us in that little room. I think I'll have a word with the doctor. Just as she spoke, Dr. Raghavan entered the room.
So is this something very regular we get to see?
Yes.
Very regular?
Yes.
When the patient comes in, for example, especially in emergency room, when the patient comes in, patient's expectations are different. What they expect is, please do whatever you can do to save me or to relieve me of my problem. But expectations keep changing with time. See, it clearly said right in the beginning, the patient was immediately taken in. He was immediately attended by the doctor. So there was no lapse in care. But where was the lapse?
It was
communication.
Nobody told her what is going on, whether they are planning a 2D echo. They had not given her any idea and she's sitting there clueless. So she thought they're not doing anything. So
Exactly.
this whole thing could have been avoided if somebody sat with her for 2 minutes and told her this is the next plan of care and this is what needs to be done.
But isn't this a regular thing we get to see in most of the places?
Yes, it is so regular that, sometimes even when you are not busy, you're doing this.
Absolutely. Even when we are not busy, we are doing this. So I remember I was, taking a session for postgraduate students. So one of them, she said that my father was admitted in one of the corporate hospitals, big hospital, not like Sarkari hospital. She said, my sister is a doctor, I am a doctor, my brother-in-law is a doctor. My father had fever for almost good 10 days. So we were concerned, what is the reason for the fever? She said, the moment I would try to speak to the consultant asking about what's wrong and what is your reading or what the new reports have kind of, indicated, he would just not stand and talk. I had to literally run after him to get the answers. So we really got to see, are we understanding it's not just about treating the patient, it's also communicating the family. Now, what do you think failed in the whole communication? What do you think completely failed in the communication?
I think it's both ways. Of course, the expectations here lies with the doctor that he could have told her that the exam is done, vitals are stable, so far there's nothing, but we want to keep him for observation.
Okay.
And this observation would take this time.
Yeah.
Considering he was busy or he was, he had to attend someone, he could have at least made sure that his nurse communicated the same fact to him. I think that's where there are two ways to look at it. Either the doctor insists his nurse or his team, some members of the team, an intern, a JR, a PG, whoever, to go forward and inform this to the patient. Or proactively, it should also come from the junior staff that they had done it.
Yeah.
Like,
but why not, Dr. Gaurang, why not doctor before leaving the patient? If he says, right now, everything seems okay, but we would still like to observe. Therefore, we are keeping him. Is this communication very difficult?
No, not at all. Not at all difficult.
So
he could have done that.
Yeah, right in the beginning, he could have done. And then it said that nurses came into the room number of times. Did they try to talk or ask or inform?
No, they also did not do. And the worst part, I think, of the case scenario was when Zeenath went forward and asked the nurse. The nurse who knows the plan of action did not do it then.
Absolutely. Even then
she could have as well completed, solved the case then and there.
Yeah.
So she was knowing, she knew what she was doing. So she could have told it then and there to Zeenath. And this could have prevented a miscommunication or a difference in understanding between Raghavan and Zeenath.
Absolutely. So you see, patient's expectations change. One, right? Like, so for example, initially patient expected that I need to be treated. So they didn't expect much of communication. But when the patient was put on monitoring, or if something was planned for the patient and the family today expect to be told that what are you expecting, or what are you thinking it could be. It could be a differential diagnosis. It could be a number of things. It could actually be a cardiac problem. But if you're thinking, okay, we need to get the ECG done. After the ECG, you think we need to do the echo done, or whatever you're planning. The patient's family want to know what is being done. Also, patient's family today expect to be involved in the options available for treatment. We are just saying admit. We need to admit, are you okay with admission? Again, in government setup, they'll be more than happy if you admit them. In a private setup, they know admission means expenditure. Admission means I have to arrange for my insurance in case I'm already insured. Admission means somebody will have to be with the patient here. Admission means some expense from our side, even if I'm insured. So see the requirements that the patient will have. So it's very different. I know in both these setup it is very different, but then they want to know. Then of course, if you say surgery, earlier I remember when you would just say surgery hogi, then patient will not ask kya hogi, kab hogi. Today they want to know why surgery, why not something else. For example, if patient comes with renal stone and you say surgery, they'll ask you 10 questions. Can we not remove it with medicines? We know there are homeopathic medicines available, there are allopathic medicines available, Ayurvedic medicines available. They would want to know. So we can't just assume that the patient will just listen or agree with what we are saying, especially when they are coming to a corporate hospital. Did you notice one thing? What the nurse said to the doctor?
Yeah.
What is it that you noticed in that was not okay, what she said?
She said they want to leave home.
They want to leave home. And
that Zeenath feels that nothing's being done here.
Exactly.
I think that
exactly
is tweaking the conversation a little.
Yeah,
I
it's
think
sarcasm. It is sarcasm. So this is how sometimes we fuel the situation by adding unnecessary comments. That was not something she said or meant. One thing, not only meeting her requirement, but also when you're communicating to the next person, you may add your viewpoint to it and fuel the situation. And what did the doctor do? He became aggressive.
He said might be she's bored and wants to leave home.
Exactly. So imagine how things can go wrong when we are talking in a unprofessional way. So in a professional setup, I think even that's a very important message. We can't talk irrelevant things in a professional setup. So this is how I think there are a couple of yes please.
मुझे लगता है कि नर्स ने डॉक्टर के अंदर के रावण को जगा दिया था.
And see, very easily we get influenced. If somebody is said by somebody who knows me, I would just not check the truthfulness or any other perspective to it. We would just assume and we'll react to that. And in a very reactionary manner, he literally, shouted at the patient's attendant.
I think, I just quickly remembered when I had my orientation for my internship, our director was taking a just lecture on, interdepartmental communication. So when we write referrals or when we speak, he says, when there's communication, the crux is always X. But when it's presented at different ends, it's always X plus 2 or X minus 2. And at least X plus 2, X minus 2 is fine. But he said sometimes if it's 2X or X square or it's X divided by 2, it's going to cost you lives.
Absolutely. So true. But a simple way of explaining that how things can get distorted and how fatalistic it can be. Absolutely. Any other observation about the case study that we have not discussed?
we can also see one thing,
Mhm.
and there is no other support system. Of course, the communication is definitely missing.
Yeah.
And lack of empathy can be seen.
Mhm. Mhm.
He was there, and all that was required was being done. But empathy would have brought in some more communication.
Absolutely. Absolutely.
The doctor is supposed, he's the decision maker.
Yeah.
Supposed to communicate, maybe a line or two. But if he communicates, as you said, and after coming back, also, I didn't, the rest part of the story is not there. But I hope the doctor asked them what was going on.
I wish. I wish.
No, but I think one thing what Zenith did was right. She also did not blindly believe what Katrina said. If we go with the tweaking part, what Katrina tried to communicate was also not the exact crux, the way he communicated.
Yeah.
There's a little tweaking there. Probably that's anxiety. It's
Yeah.
understandable. But Zenith was very clear in that frame of mind that no, she's not just buying what Katrina said, and she will have a word with Raghavan directly herself.
And I don't know
think
what
that's
kind of
also-
communication they really had later on. Yeah, Dr. Ila, you have a point to add. Please go ahead. Yeah.
No, as you said, actually, what happens now, generally, we, in fact, last session also we discussed that we must understand our client as an intelligent client.
Yeah.
Don't assume okay, it is not required for them to understand,
Yeah.
or it's okay, let me do what I need to do. There's no need to tell them whatever we are doing, but there is a need to tell them each and even if they understand, they don't understand. We should explain them. We should try explaining them. It is like that. It is, don't assume that they will not understand. My point is that it is just that
Even if they don't understand your language, you have to make it understandable.
Make them understand.
Especially in the time of international tourism, medical tourism that we are experiencing in a lot of hospitals. People have kept translators. People have actually learned. They have those apps and those equipments to help patient and the coordinator, communicate, because there we know we get money out of it. We are making all the effort to communicate with the patient because we know the patient is going to pay for that. But what about those patients who are already there with us, but they are not going to be, like they're not like international patients by you. I think that's where we are trying to understand how we need to really.
And this I was just acknowledged with this fact with my personal experience when my brother is into finance.
Yeah.
So I don't understand much finance, what kind of investment we do. Medical background people generally we don't understand. So when I was asking him, what do you do? Why you are doing this? I mean, when for which my money, why you are doing this and not that? He said, you don't need to understand. I'll do that.
Exactly.
And then I felt so bad that time. I said, why I don't need to? So what if I don't know? You make me understand what are you doing with me.
They would normally think that you don't understand, so you need not be even explained.
So you trust me. I know I trust you, but you explain me.
Absolutely.
I trust you, but still you explain me what you're doing with that. So that is where I got acknowledged. This is how it works with others also.
Absolutely. So I think this case study, though it's a very simple case study that we discussed, and I've given you a couple of more case studies. When you will look at those case studies, you can use these case studies and even design your own case study to talk to your audience, depending upon the training needs that you have. So if you think you want to talk about, rude behavior or arrogant patient or, conflict, develop a case study around it. And case study is a very powerful tool to bring brainstorming and also make people, reflect on what we do. A lot of people will not admit that this is how I also behave. Those who are in patient handling, they will never say, okay, this is how I behave. But then in the heart of their heart, they reflect, okay, even I do this. I don't go and tell the patient and their family that this is our plan of action. Only if the family comes and asks what next, and then I will say. And a lot of time when patient's family would come and ask, discharge mil jayega aaj, dekhte hain, that's my answer. So that means I need to be more, clear and specific in my answer. So it's a case study is a wonderful way to, bring people together, make them talk, brainstorm, understand each other's perspective. And a lot of time, the same case study will have different perspective added to it. Then you will make people speak. So it's a very simple tool, but a very useful tool. And we talked about patients' expectations. I think even that imagination part, that activity that we did, that gave you a good idea how you can see things from the patient's point of view. Pooja, you have anything to add?
Yeah, ma'am, one observation,
Yeah.
which is like, because I've been involved in many a times the nurses.
I'm so sorry. Please unmute. Please unmute. Sorry.
Yeah, so this the role of the nurse here, no, like many a times, like even when we visit, I mean, I visit hospital as a patient also have been there. So the answers from the nurses are more or less, it would be, on the same line. Doctor se puch ke batate hain, let me check with the doctor. Even though she knows, practically, because this is a common, thing that they are doing there. But still, this, the satisfaction level never, the patient very rarely they get it. And this is one of the challenges that the nursing leaders also face, that there is some lack of confidence among the nurses. If the nurses know this particular area aspect, nothing on the care part, but specifically this communication part and the confidence part, if this bridging helps, I think this will help the clinicians also pretty much.
Absolutely.
Like, no, so there is a helping hand round, particularly for the communication part itself.
So there is nothing wrong even in saying I don't know and let me find out for you. It's all right. But if I find out and come back to you and tell you that this is what is the answer, that's also good enough. It's always better to confirm before you share any information, because you may communicate a wrong information and that can cause. आपने कह दिया surgery नहीं होगी, doctors कहते surgery नहीं होगी. I remember in COVID time, one of my known to for his mother, somebody said ये injection लाना है, or somebody said ये injection नहीं देने की जरूरत है. Now imagine the confusion. He says my mother is on deathbed. And one person is saying ये injection लाना है, another person is saying इसकी जरूरत नहीं है. And getting that injection was a big problem at that time. So it's all right if you say I don't know, but let me find out and tell you. Complete the loop. Don't leave it unanswered. I think that's the message I would give. So there are a lot of case studies. There's one on the cancer patient. I wish you all read that, and you will understand what cancer patients go through and how they feel, and how the treating doctor is at a different place and the patient and the family is at a different place. And most of the times, because we are so used to seeing patients with cancer conditions, our way of talking to them sometimes becomes very insensitive and to the point. I remember one of my known to being said, post treatment, she was okay for 5 years and she had relapsed. She had metastasis. And then when she went back with her brother and everybody to the doctor, he said, 4-5 साल जी लिया आपने तो बहुत बड़ी बात है. और क्या चाहिए? I mean, you make such statements without realizing, I mean, how will that impact the patient? I think I'm being insensitive when I talk like this. So let me quickly show you the presentation on the topic, understanding patient expectation. And I'm trying to help you to see patient as a consumer or as a customer, so that we know if I'm charging the patient, if I'm being paid for these services, I'm supposed to meeting those expectations. So let me quickly share the very small presentation, but then that will add. Oh, I'm so sorry. But I'll advise you to look at all the case studies, and also in case if you want to develop your own, you can even go ahead with the one week that you need to. Yeah.
So, Dr. Indu, this case study was like a storytelling pedagogy, right? Because this storytelling, or are you? I mean, I'm supposed to understand these are like real case studies minus the names of the patients, right?
This is not a real case study. This was picked up generally, randomly. Like this is what we normally see in any hospital. I think we don't require any specific details of it, because I think in emergency, most of the times this is what happens. We take the patient in, we treat the patient, but we don't inform the family. And they are waiting outside, waiting to be updated, especially if I talk about the government setup. Of course, in private, it is slightly better because we know now we talk to the patient and the family a bit. But in government setup, Dr. Dipti can tell us better. Dr. Dipti, what do you say?
Right.
Is this something not a regular thing?
This is in fact, this is, if I may say, more of a routine.
Absolutely.
And I am becoming wiser with your inputs. Today on my post time around, only a patient had come after hysterectomy with bladder injury. She has got a urinic ascites in her abdomen. Patient has come at 6 a.m. and I took the round at almost 11 a.m. So 5 hours. There was hardly any communication with the patient's son. That's what has happened. At least tell them what they're expecting. I mean, I'm sure they must be waiting with bated breath that she was operated in Ghaziabad somewhere. We have brought her here with a distended abdomen and no urine output. So something is wrong. हमने test भेजे हैं, हम ultrasound कराएंगे. I mean, that is the minimum. And nurses, I mean, in government setup, it's pretty bad. It's pretty bad. वो अपना काम कर दे ही बहुत है. Talking to patient is too high. But I spoke in front of my whole team. We drew a diagram and showed them where the injury could have occurred without actually talking ill of the doctor. We said that when the uterus comes out, the bladder also comes out, and this can happen, and it has happened, and we are getting it done, and we will let you know. Even now, while I was getting messages about that patient only, that we are getting a cystogram done and patient is being taken up by the surgeon or whatever. But I realized that son was satisfied once my colleague drew a diagram, told. This is in very matter of fact manner, without maligning a fellow doctor also. In our profession, that is very important. If somebody comes with complication from somewhere, I mean, this is a disease of telling कि आपने कहाँ operation करा लिया, वो तो डॉक्टर से नहीं है, आप पहले हमारी तरफ आ जाए होते, आपने 25,000 रुपए खर्च भी करे, देखो क्या करा के आ गए आप. I'm making them feel all more miserable. And maybe if it were older me 10 years back, I would have done the same.
And that's very common. Professional jousting is very common. People from government sector, when they go to private, the private people will say, government hospital में कोई देखता नहीं है, कोई attend करने वाला नहीं, आप वहाँ कहाँ चले गए? And when they come from a private setup to a government, then we'll say कि पैसे ले लेते हैं, इलाज करते नहीं है, केस खराब करके हमारे पास भेज देते हैं. And this is how we actually, talk ill about each other and bring down the image of our profession.
We're talking ill about our community as a whole. And
yes, exactly. I completely agree with you. So very quickly talking about the patient's expectation, let me tell you a story, not a story, but this study that I want to share with you. According to this study, give me 1 second. Yeah, I hope it works. Yeah, 45% of the families reported feeling unempowered in the treatment of their patient. This was a survey done recently by a couple of organizations together in 2019, and it's an Indian study, so I think you will really find it interesting. They also felt that they did not have clarity on diagnosis, and they reported rushed consultation, and they also perceived lack of involvement in deciding the treatment and lack of clarity on treatment and care option. And I think you will completely agree with me. Most of the times we do not inform the patient, clarify things, we do not involve them or explain them. Like Dr. Dipti said that I took out time and explained and drew. I am not very sure, Dr. Dipti, how many of the doctors in your setup will actually be doing it than your initiative and your team's initiative. I mean, I really doubt. So, and this is like 50% of the patients have reported that they are never explained about it. Similarly, according to the same study, 35% of the patient indicated that they were not allowed to describe their condition or symptoms. Because when it comes to talking about their problems, we all know that we want the patient to cut short or to only answer our questions rather than just narrating their study. So as a result, they are not allowed to speak about their condition or talk about their condition. Also, 32% of the patient, almost like 1/3 of the patients, indicated that the doctor or the staff did not straightforwardly address their questions and doubts. And I think this is what we are discussing right now. So I'm going to introduce you Kano's model. Have you heard of Kano's model? Has anybody heard of Kano's model?
No, I have not.
We have not, but you will like it. It's very simple, and it's very simple, but it will give you a lot of ideas about how do we really, understand our patient's expectations and meet them. So the first level expectation that the patient would have, they're called basic expectation. These are the expectations. When they are met, it's something like, it's nothing very, extraordinary that you have done. That is expected, and you are supposed to be meeting them. So they are more like unspoken expectations. When they are not met, there is a lot of hue and cry. But when they are met, nobody even acknowledges. For example, a patient has come to your hospital in the OPD. So having a waiting area or having a reception, having a doctor in the chamber is something that is expected. So they will not acknowledge, oh, you have a waiting area, oh, you have a reception, oh, you have a doctor in the room. No, that's not going to be acknowledged. Rather, when it is not met, they are going to be dissatisfied. So this is just a basic facilities, basic services, basic manpower, basic infrastructure that you need to have. And I think to run a show, I think this is something that we all need to bare minimum have. But don't expect any appreciation for this or acknowledgement for this. So this is basic level. Some of the examples, like for example, if the patient is admitted, definitely there will be a bed. No, there will be a clean sheet. There will be a toilet, neat and clean toilet. So this is something very basic, and they are not going to really acknowledge it. The second level of needs that's called is satisfiers or performers. So for any healthcare delivery system to exist and continue and sustain themselves, I think this is second, which you really need to focus, because that's what is going to create patient satisfaction. For example, expectations that when they are met, patient is satisfied and happy. If the sheet is clean, if the toilet is cleaned twice in a day, if the housekeeping staff comes on every bell, if in the OPD there are fans, if there are clean toilets, that's something, if they are there, patient will be satisfied and they will be happy. Oh, that's a good place, neat and clean place. There's no noise, there's a lot of ventilation. But when these things are not met, patients are going to be dissatisfied and they are going to be complaining about it. Can you give some of the examples from your setup that you think they are satisfiers?
Serving the hot food.
Okay, getting hot food, very true.
Cleanliness.
Cleanliness, absolutely. Even less waiting time.
Medicines being administered on time.
Medicines administered on time. Lab reports available on time.
Housekeeping available whenever they are calling for.
Absolutely. When they are called for, if they, whoever, for whatever purpose we have called, that service is provided, they are more than happy that, okay, I was given a prompt service. The third level need that we talk about is they are delighters. So when we talk about delighters, I know in government setup, we don't think of delighters. We only think of basic things and, if possible, performers. I think we are just stuck still with the basic needs, if we can provide them basic things. But in private setup, I do see it everybody making a lot of effort to, arrange something that's called delighter. So delighters these are the requirements the patient will have, but will not expect the hospital to meet. But when they are met, they feel very happy. For example, if you have given an appointment to a patient for coming for a test or for next consultation, but you see your machine is out of order, or you see the doctor will not be available and is on leave or has some reason not to be in the OPD, and you promptly before time inform them that please do not visit on this date, your visit is rescheduled for this date, or the machine is out of order, please visit on this date rather than this date. So that's going to be a delighter. Now I see corporate hospitals make a lot of efforts to create delighters, because that's the way they think they can hold the patient, they can, keep the patient happy, delighted. Can you give me some examples from your setup that you all are doing?
In our hospital, when it's the patient's birthday, they arrange for a cake and they don't know that that's happening. So
absolutely,
it's always a surprise and they're very, very happy and the relative is very touched and grateful.
Absolutely. Even I have seen this happening. I completely agree.
Availability of Wi-Fi services.
Oh yes, availability of Wi-Fi services. That's something a delight. Absolutely. Wonderful. What else?
I think for me, the first one is, at least in government setup, it's addressing patient by the name.
Yeah. Imagine. I mean, but such a small thing that can be a delighter for a patient. Absolutely.
Most of the times when we present cases or when senior consultants are coming on round, it's very difficult to expect senior consultants to know all the patients by name, but the intern or the chair who's actually following up the case, at least they should know some personal things about the patient, have some kind of conversation. I'm not saying enter their personal space, but I think that personal touch will make a huge difference, and that's a very basic expectation. to pronounce their
knowing
name
personal
appropriately.
details is also very important and relevant, Dr. Gaurang. Only thing is we don't have to intervene into it because unless it is, affecting the treatment or if it is required for the treatment purpose. But I always say when we talk about biopsychosocial model of patient interviewing, I say you must have a lot of information about the patient's background. That will really help you in designing. This is what I talk to the medical students. So I'm not bringing in here. When I talk about that Calgary Cambridge guide, I do talk about collecting information about background of the patient. Because when you're designing their treatment, you will know the family dynamics. You will know who is the primary caretaker. You will know, do the patient have support system at home? So when you are planning the management of the condition, you will keep these things in mind and then plan the management. That's where these things will help. But definitely we don't have to interfere into their personal matter unless it has nothing to do with the treatment. I completely agree. Yeah. So, but somebody knowing the patient's name, I remember one of the doctor would always have the patient's card beforehand. They will read the name and certain details and then start interacting with the patient by calling his or her name. And patients, as you said very rightly, they'll be very, very happy. Oh, doctor knows my name. And if it's patient's attendant, if you call them by name, we will be doing this when we'll talk about the breaking of bad news. I'll be giving you a demo on it. How knowing the patient's attendant names can actually help things calm down. We'll talk about that. Wonderful. Any other example of delighter that you can think of?
Ma'am, I would like to add one point
Sure.
for making the delivery packages and all, like the delivery experience of normal delivery or cesarean delivery to taking it to a different level. Private hospitals are making such, programs and packages to make it a completely memorable experience for the parents.
Absolutely. So my daughter recently delivered a baby boy, in one of the hospitals in America. So
congratulations.
Thank you so much. Thank you.
Many congratulations, ma'am.
Thank you so much. Thank you. So, they have a facility of having in-house photography. So a photographer will come and they will capture pictures of your, baby. They'll also come with the props, basket and all those things. They'll have, they'll bring a caddy and other things, and they'll take beautiful pictures of your child. And then they'll give you, I think, 2 or 3 complimentary pictures. And if you want the whole set of pictures, then probably you have to pay for it. But that's a delight because you, on your own, you can't, think of getting a camera and capturing your child's picture because you're already, exhausted with the whole process. But then they have this in-house facility. So I'm sure people are becoming more and more, innovative in finding ways how to delight the other person.
But I'm happy this is actually happening in India, ma'am. I know a few centers personally, especially in Gujarat. Especially for the delivery, as you rightly said, this is happening, and I have, being closely associated, I've got to know that in the feedback form, what makes this hospital special in comparison to other, this has been showing a striking percentage. There's a actually
yes, it is, and even they plan programs for during the 9 months pregnancy. For the moms to be parents, pre-delivery programs. So many things have been coming up. So all these things are already there. But yes,
exercises, dietary guidance, psychological, mental health guidance, well-being guidance. I think these are all really being integrated with the antenatal phase, and that's really picking up very, very well. So this is just to show you the patient satisfier. I think as a lot of you have pointed out, communication with the nurses is the first thing that they look for. If we can empower our nurses with the right knowledge and confidence and information, that can really improve your healthcare delivery system. So a lot of hospitals that are going for NABH accreditation, nursing excellence really brings a real change in the performance and patient satisfaction. And if you can promote that, that will really help you promoting the name of your institution. Second is, of course, communication with the doctors. Third is communication about medicines. They want to know about medicines. When it is not explained well, they are confused and there are possibility of making error with the medicines. Fourth, of course, is responsiveness of all the hospital staff. So wherever they go, lab, radiology, pharmacy, front desk staff, everybody, the way they behave, the way they respond makes a lot of difference. Another thing is pain management. How promptly is their pain really addressed? In Western countries, nurses are responsible for pain management. So on 4-hourly basis, they are supposed to be, getting the rating from the patient, asking, rate your pain from 0 to 1, 0 to 10 on the board for them in their room. So based on that, they have to do the pain management, because if the patient stays in unnecessary pain for a longer time, they're going to be dissatisfied that nobody understood my plight and nobody tried to help me. So for me, in case if you ask me, for my second daughter, all through my pregnancy, I had, pain, which nobody could diagnose. And I was very unhappy with my gynec at that time, that she could not diagnose. It was later on when I was operated for my second child, we got to know that I had ectopic pregnancy. And because of ectopic pregnancy, I had adhesions in my peritoneum. And that was the cause of, pain in my, continuous pain in my. And then I had a number of other medical conditions which were not diagnosed that time, but now I'm getting to know what is the reason. But I still have the memory of, having pain. Yeah, Monica, you want to say something? Okay, so 6th is cleanliness and quietness of the hospital environment. Again, very important. I think we are looking after, but in government setup, I think we are not able to create that kind of change seriously. Of course, discharge instructions is another source of patient satisfaction. How clearly are they informed? How their questions are answered? How their concerns are addressed? Suppose the patient has come from a different place. So what about my follow-up? How will I come for follow-up? Whom can I call in case if I need any help? Suppose if I need any medical intervention, immediately, where do I go? For example, I got my sister-in-law operated in Delhi for bariatric surgery, and she was from Bangalore. So for her to get her follow-up there in Bangalore, if somebody could create a liaison, she would have been very, very happy. But if the doctor is not able to do all that, they feel that, how do I really, get my follow-up when I'm not in the same place? Then, of course, the overall rating of the hospital. Patients now really, really Google search. They look for reviews. They look for, and if your overall rating is not okay, trust me, that's also going to bring down their, their impression of your hospital. Now, talking about the concept of design thinking, Dr. Shashikala, are you there? Dr. Shashikala, are you there?
Yes, ma'am, but I'm traveling. I'm just on the phone.
That's why I did not ask you to have your video on. So I'm just asking, have you heard of the concept of design thinking?
Yes, ma'am. Yes.
Okay. So can you explain in your words what is design thinking?
From problem to solution, you will have a pathway to follow. And there is a problem, then it is organized once. Suddenly, I'm not able to express it, but that is the funnel is there, then the filtering, all that.
Okay, that's all right. Thank you. So friends, concept of design thinking is a very innovative way of actually understanding what do my client requires. So for example, if I'm talking about Amazon, Uber, VFast, Oyo, Zomato, and even IHC, we are looking at the problem not as a problem, but as a challenge that we need to solve. And how can we give the best service or best product depending upon the requirement of the patient. So it's all about understanding what do my patient needs. For example, to start with, you first of all identify what is the problem. So if I take the example of your OPD, if you think there's a long waiting time or the waiting area is not sufficient or the waiting or the whole OPD is not being organized very well, so probably that could be your problem definition. So whatever you want to work on or whatever service you want to provide, if you identify that, and how do you go about finding a best solution for that problem is nothing but design thinking. So in that, the first is empathy building. So when I made you do that imaginary visit to your hospital, it was empathy building. So you went to different areas as a patient and you realize and observe what must your patients be experiencing. So if you really want to resolve the problem from the client's point of view, you need to be with the client, go with the client. In Harvard, to their management students, as part of their internship, MBA students are made to work with every cadre of employee for a couple of days, even with the delivery boy. Of course, now we have most of the things being moved on, on internet. But suppose if some package has to be done, again, now we have system who would pick up your stuff and go and deliver it. But they usually we had delivery boys who would personally go and deliver the things. Even with the delivery boys, those MBA interns were made to go to see what challenges they experience when it comes to going and delivering a product or a service or something. So empathy building is when you walk with your client to every area where they are visiting. And then next is which ideas could solve the problem. So once you have done that process mapping, once you have gone to the area with them, now you sit and identify which areas I need to focus on, and then collectively. So always design thinking is done as a group activity. So you will come back to your conference room and tell, okay, this is what everybody visits, like we do field visit or we do hospital visit, around that we do. So when you do it collectively, but you do it from the patient's point of view, not your administrator point of view. And then you come and sit together and then you start having ideations where you all creatively come up with ideas that you think will work. So usually this activity is done in a group with stickies on the board. So there is no name on the idea, but you just put the idea, okay, we can do this, we can do this, these are the ways we can improve these services. So maybe your concept is improving OPD services or improving waiting area. And then everybody gives their ideas and you put it on the board in the form of stickies. Now you once start picking up one by one and start, putting them in one column. So you will see a lot of ideas will have a lot of people will give common ideas. So that means as a group you collectively have found that this idea will work. So based on the answers that you receive from everybody from your team, you will realize, okay, these ideas are something that will really work to resolve the problem. Then you create a prototype. So prototype is more like a pilot study, if I may say. You will apply that to a smaller population, to a smaller area, to a smaller service. And if that works, that once you have developed that prototype, then you test it, whether it works or not. You also take feedback from all stakeholders. For example, if I'm saying, okay, let's improve the waiting area in this manner, I would even take the feedback not just from the patient, but from my own team members working in that area. What do they think? What challenges are they facing? What difficulties are they facing because the change that we are planning? And then if that works, then you implement and generalize to every area. In healthcare, it is striking slightly later, but yes, it is striking. For example, you may have seen in a lot of hospitals, their MRI and CT scans for kids especially will have, this kind of renovation. Has anybody seen this, something like this? We have all seen it. So this is nothing but that they are trying to, look at it from the pediatric patient's point of view. So when pediatric patients and their parents come in for CT or MRI, they are overwhelmed, first of all, by the hospital, by the disease, by the condition. And then how do you really calm them down, make it easy, comfortable for them? So that's what they are trying to do. I think I visited another government hospital in Delhi, that is Chacha Nehru Bal Chikitsalaya. So I saw a lot of their corridors and their lifts and areas decorated like this, would have, paintings and then cartoon characters, just to relax the child, just to make the child feel comfortable and feel familiar with the environment and bring down their, anxiety and fear. So I'm sure in OPDs, a lot of places we are getting to see something like this. This is waiting area of one of the hospitals. Then this one is, the Apollo Cradle. I think some of you may have seen this. Again, waiting area of one of the, Dr. Gaurang, you want to say something? Go ahead.
Yeah, so I just quickly realized this, that I didn't know that this was concept of design thinking, but during the pediatric posting, 4th year, we used to have the clerical posting. So only task with the HOD insisted that word, we used to interact with all the inpatients. We had to go ask them about their favorite cartoons. We found it funny, but which during our holiday, we ensured now that you have the list of cartoons they like, you know, for our batch specifically, and we and our social services committee, along with one more NGO, we went forward and drew. We completely painted all by ourselves. You know, Doraemon, Pokemon, and all of it. But now that I see, you know, retrospectively, I realized that asking what they wanted and then trying to implement it because we wanted to make them feel better and empathize with them is the concept of design thinking.
Absolutely.
Just wanted to share this method.
Absolutely, absolutely. So now you can see that this concept is infiltrating even in healthcare. We are seeing things from the patients and their families' point of view. So my first encounter with design thinking was somewhere in, say, 35 years ago when Escorts Hospital came in Delhi. So I had gone to visit my husband's aunt in that hospital. The moment I entered, to me it appeared that I'm entering a 5-star hotel. So they had a huge waiting area, then they had a coffee shop, then they have a gift shop, then they had a bookshop, and they also have, you know, a lot of good fast food counters there. And I was surprised that why do we need all these things? But now we realize that patient is far more comfortable when the patient has a bed and a room and a nurse and a doctor to look after. It's the family who suffers almost equal or more than the patient, because they are waiting outside in corridors. They don't have a place to sit, and they have so many days where they need to sit day and night. What about their biological need? What about their sleep, rest, food, changing clothes, bathing? So I think now we are realizing it's not just the patient that we need to look after, it is the family we need to look after. And more we are realizing, I think more we are able to create facilities, not just for the patient, but also for the family. So I think it's time that we understand our patient's expectation and meet them midway. And design thinking is a wonderful way to understand your patient's expectation and how you can do it. So as a homework or as an assignment or as your free will activity, you can try something like this in your hospital where you design, you know, services, keeping the hospital, the patients or the clients in your mind. So you could even think of, you know, something like designing the hospital OPD services without making much changes. How can you improve the services to your patient and make them feel better? Okay, so with this, we come to the end, the presentation on patient expectation. Any questions about it? No problem. We will start with Pooja's presentation. Pooja, are you ready? So I'll share the, I'll enable you to share your screen. Give me a second. Dr. Shashikala, are you going to present today? Dr. Shashikala? It's okay. I think, Pooja, you can go ahead with your presentation. And we are left with just 15 minutes time, so you can complete your presentation. Yeah, go ahead, please.
Yeah, so very good evening to everyone. The topic that chosen for today is on role plays. So it's a very, all of us have heard about this concept of role plays. I think, even during our childhood also, we used to play a lot of these damsharas and all these things. Many ways are there to express. That's the role play thing which we are going to discuss today. It's a fun learning exercise, and to be very simple, it is something which is how we learn by experiencing that. So all the discussions that we had about empathy and about understanding the other person's perspective, these all things can be very easily understood by this technique. So without going into the presentation mode, I would just like to start it with a practical exercise to start this concept of role play. So I would be needing 2 volunteers from the group who are willing to experience this this thing, and helping others also to understand. So 2 volunteers, please. Dr. Ila and Dr. Deepti. Good. So thank you so much. So the thing is, what you're going to do right now is actually not the appropriate way to do role play, but since we are just trying to understand how exactly it is done, so I'll just start it that manner. So there is a case, and all of us are observers here. So we'll take the feedbacks and discussions from everybody based upon what have we observed of these 2 communications. So this is a small case of leave against medical advice, or LAMA, as all of you would be knowing this. So herein there is a patient. Okay, the patient is a multi-organ failure case is there, and there is very little to no hope according to the patient's family. Now the patient's family is economically not that sound, and they don't want to keep the patient in the hospital because of a lot of understandings about this all things which happens in a hospital, which as a perception over there. So the patient family don't want to keep the patient in the hospital, they want to take the patient outside. And so one of you would be the patient family member or the attender for the patient. Maybe like you can be the husband of the patient, or any relative, you can choose it. And the other person needs to be the consultant with whom he is going to discuss this case. Simple, very very
so let's make it Pooja, let's make it a little specific so that it doesn't take very long. It's just 2-3 minutes role play, where one of you will act as the patient's attendant who want to take the patient LAMA, that is left against medical advice, and the other one will be the doctor on duty. And whatever conversation you want to have, of course the doctor would try to explain why not to take LAMA, and the other one will have a point that I want to take the patient. Just we want to see what is role play. That's what we are focusing on. And I think Dr. Diti has fair idea about it because she has done a lot of role play. So I think we can have it.
So who am I?
Yeah, it's better if
you
we
become
all
the consultant, madam. Madam, you become the consultant. I'll become the patient relative.
Okay, but just keep it 2-3 minutes, not very long one. And all of us will stop our videos so that we can see both of them, practicing. Yeah.
हाँ जी, अमृता जी.
अच्छा, we have to start. Okay. Yes, madam. मैडम कैसे है पेशेंट का तबीयत?
आप आइए, बैठिए, मैं बताती हूँ. आपके पेशेंट का आपको हमने पहले भी बताया है, हालत तो अच्छी नहीं है और उनके किडनीज जिसको गुर्दा बोलते हैं और सही तरह से काम नहीं कर रही हैं. अभी उसके बाद और भी कॉम्प्लिकेशंस पैदा हो रही हैं जिसकी वजह से उन्हें भी यहाँ भर्ती रहना चाहिए.
ओके, लेकिन मैडम ऑलरेडी 1 महीने के ऊपर हो गया है, इतने सारे ट्रीटमेंट कर चुके हैं हम. अभी आपको तो शायद पता होगा खर्चा भी बहुत सारा हो गया है, तो अभी कैसे बढ़ेंगे आगे?
मैं बिल्कुल समझती हूँ कि खर्चे की बात मैं आपकी समझ सकती हूँ, क्योंकि उनके 2-3 ऑर्गन्स इस समय 2-3 शरीर की जो गुदा है और अब लिवर की ये जिगर बोलते हैं उसकी भी कॉम्प्लिकेशंस आ रहे हैं. तो हमारी पूरी कोशिश जारी है जिससे कि थोड़ी इम्प्रूवमेंट आए. थोड़ा बहुत ज्यादा इम्प्रूवमेंट तो नहीं है, लेकिन एग्जैक्टली बहुत खराब केस भी नहीं है, इन द सेंस के जैसी पोजीशन 2-3 दिन में है वैसे ही चल रही है, इसके बाद और खराब नहीं हो रही है. तो ऐसे में अगर हम कंटिन्यूड सपोर्ट रखें डायलिसिस का, तो कई बार थोड़ी रिकवरी ऑफ फंक्शन होके मरीज बेहतर स्थिति में भी आ जाता है. इसी उम्मीद से हम उसको आगे रखना चाह रहे हैं अपने पास.
तो आपके हिसाब से मैडम परसेंटेज कोई है क्या सक्सेस रिकवरी का, कितना चांस है? मतलब क्योंकि क्या है, घर वालों को भी देखना है, आने जाने में ये सब बहुत सारी दिक्कत हो गई है.
मैं बिल्कुल समझती हूँ, ये बहुत कठिन हालात है जिनमें आप हैं इस समय. मैं इसके चांसेस कोई 15 से 20% दे सकती हूँ, ऐसा मुझे लगता है. ऐसे मरीजों में आ जाते हैं, अच्छे चांसेस नहीं है लेकिन जीरो भी नहीं है.
क्या है, फैमिली में भी सब मेंबर्स वही बता रहे हैं कि अभी इतना कर दिया, अभी और उनको शांति से घर पे लेके आ जाओ, अगर उनको जाना है तो ऐसे ही चले जाएंगे, एटलीस्ट घर में आके जाएंगे वो, यू नो।
मैं
इस
एक
तरह की सब बातें
आपको
कर रहे हैं।
सजेशन दूं, एक आपको सजेशन दूं, समझ में आ रहा है खर्चे को लेके काफी दिक्कत है। मेरे एक मित्र यहाँ नजदीक के सरकारी अस्पताल में, बड़ा अस्पताल है, वहां पर है आईसीयू इंचार्ज। मैं उनसे बात करके अगर मरीज को वहां शिफ्ट करा दे तो क्या आप वहां इलाज करना चाहोगे, जिससे कि कम से कम पैसे की समस्या का थोड़ा समाधान हो जाएगा और वो एक अच्छा सेटअप है। मुझे लगता है कि मरीज को एक अच्छी केयर मिलेगी। तो जो हम थोड़ा करना चाह रहे हैं शायद उनको मदद मिल जाए।
कोशिश कर सकते हैं मैडम, अगर बेड मिल जाएगा तो कोशिश कर सकते हैं।
जी, वो मैं बिल्कुल कोशिश करूंगी और आपको एक पर्चे पे हम पूरा लिख के और पूरा पाथवे बना के देंगे जिससे कि मरीज वहां प्रॉपरली पहुंच सके।
Sure,
very nice. This doctor is very compassionate. Can I request everybody to come in? I wish we have more doctors like Dr. Dipti.
Right.
I am what I am. I am what Dr. Hindu has made me.
See, it's always two ways. It's always two ways. If there is a receptivity, then there is a flow of, that's all I can say. You are a wonderful learner. You are a wonderful recipient. So I think I would give the credit to you. So, I mean, I didn't expect Dr. Dipti to come out with this solution. So, Dr. Pooja, please go ahead with the, although I got carried with the role play, but Dr. Pooja, please talk about the role play now. Not the role play, but that role play as a pedagogy.
Yes. So no, that what we saw was actually no, a role play, how it looks like. The thing is that I just want to understand, or no, everybody, the observers particularly.
Pooja, ask them what did
exactly
they feel. I think that's very important. Yeah.
Yes. So just coming on to the observers. So voluntarily, anybody wants to share like what they have seen in there and how you think this is relevant, particularly when we talk about the trainings that we give in the current context. Anyone like voluntarily?
We did on a very, very routine basis where finance is an issue. It's a corporate hospital. So yes, finance is an issue. And then the relatives are not happy to make this choice, but majboori say now this is the last resort ki hum ghar pe leke jayenge. And then they feel bad also for making a decision like this. So we are always telling them that, see, we understand and your decision will be respected at all costs. But there are these other options. You try talking to charity, you try doing this, you up Siddhi Vinayak Trust mein jaake, kagzat de de. So we try to help them with this, but sometimes they've just reached that point where abhi hum nahi chahte unko zyada.
Ritika, we are going out of the, no, Ritika, we are not discussing the situation. Please, this is what happens. We are talking about the pedagogy. Role play as a pedagogy. So for example, if I give my feedback, I got to see through role plays that actually you can learn to be innovative in finding solutions. You don't have to just, move like this, that, okay, only this is the solution, yes or no. I got to see, okay, role play is a wonderful way to teach people how to go out of box in finding solutions. Or role play is a very good way to experience what a doctor would experience in that role, or a patient's family would have concerns. So please remember, we are not talking about the situation. We are talking about role play as a pedagogy to teach. Go ahead, please. Yes.
Yeah. Anyone else wants? Yeah. I think Monica wants to add. Dr. Monica.
Yeah, ma'am, I was quite impressed with the tone of Dr. Deepti's voice, like how patiently and softly she was explaining. So I think that also we should understand that how the patient and the doctor communicates, the doctor communicates to the patient. That is very important. The tone of voice and the expressions.
So that means role play is a very good way to teach good behavior. good tone of voice, good body language, which verbally cannot be explained. But when they saw Dr. Dipti, they got to understand, okay, this is how I can emulate. This is how I can learn. Wonderful. Yes, Namrata.
Ma'am, I would just like to add up that role plays are basically switch on and switch off. So it completely takes us to a different zone where we have certain things in our mind which we are not able to take off our observation, our experiences, and it is switch on to that particular mode, and which actually brings to give us the all creative solutions as you spoke just few minutes back. So
Absolutely.
yes, it is a very creative and innovative way to basically bring best out of us, of our past experiences and observations.
Wonderful, wonderful.
Dr. Gaurang?
Yeah, ma'am. So I would say with regards to role plays, it becomes not just it becomes really important when we try to simulate actions. For example, not just I agree that we could learn from Deepti ma'am's composure, the way she handled the tone, etc. But I think even in emergency situations, like most of the times they call this drill, it's more or less a kind of role play. If we actually do a AHA or a PH, a BLS certification course, a BLS or ACLS, what they try to do is actually a role play. So where we get to learn the on-field dynamics. Presentation is one, that's a different part, but the on-field dynamics are equally important. So if we consider this as the same role play, here Dr. Deepti is going to be the same person, the same doctor. But again, we could have, given the time and space, if we were to use this as a pedagogy, we could use this as 3 different field dynamics, with Dr. Ila being a compliant patient, some ex-patient being a totally non-compliant patient, some troublemaker as another patient. So I think field dynamics is one more thing which we could learn from role play.
Very good. Yeah.
Absolutely. Right. Dr. Ila?
Yeah, so I just wanted to share, when we actually go through this role play, we realize what actually patient must be going through, what doctor must be going through. I mean, that's how the empathy and that learning comes across actually. That it's not just what they are going through, what problems they are going through. It's not, I have to treat here, but sometimes, I've seen some doctors who are treating patients after a month or 1.5 months. There is nothing left in the body, but still they will keep giving the hopes, which is not right actually. See, when the time comes, I'm being very honest about this. When the time comes, you must also explain that, this is the time you go for palliative care or you go home or whatever is required. It's not that you have to continue. Our job is to treat, and also our job is to not to treat when it is not required. Absolutely. So this is what I feel,
Wonderful. Thank you. So Pooja, quickly, let's go to the presentation and talk about the...
Yes. See, that's what the role plays are all about. What we have seen right now is just one skit that we have seen, but out of that, so many different things that we have different observations, and these are basically the applications part when we see about the role play. So the next thing which I was coming to was, what do you like, according to you, where and all we can use these role plays, under which context, under what kind of trainings, like suppose for communication or for the regular for front desk, 2 doctors, 2 nurses, everywhere this can be used in that manner. So coming quickly to the presentation part, I just share the screen. So this is what in just some little bit of time we will be seeing quickly about. So as Dr. Gaurav rightly told, that role plays is mainly, it's kind of a simulation itself, wherein we are not using any mechanical or any element, any device or something, but here we are just simulating the human actions over there. So by seeing how could the situation be, and we are acting according to that, and there's no risk involved in this. In fact, we'll be getting some of the solutions which we are looking forward to. The most important part when we see in particularly in role plays, the most thing which is which makes it a bit different from the other pedagogies is like it is more participative in nature. Because if you are in a role play, person would be participating in that role, and making them participate in that role is it's a kind of the job of the facilitator who is doing that program. The trainees, the people who are actually participating there, they learn with their experience and engaging themselves in the process, understanding the other person's situation, giving them the role. So the learning outcomes we can see out of, as if suppose we are using this pedagogy to for any of our the programs, the learning outcomes from the learner's perspective, A, is that they would be seeing a kind of reflection of themselves, of their behavior. Like Dipti ma'am did her character over there, but then the other people, they can simply see like how exactly she behaves in a situation. At the same time, even for Dipti ma'am also, even, and many times not directly in her context, but many a times what happens is when we are performing a role play, we perform it to perfection considering the ideal situation, but then as a person itself we are seeing that do we actually do this in actual. So that gives a very clear insight about a kind of a reflection of your own self when you're performing a role play. And obviously the learners, the people who are participating over there, they will learn about the feedbacks of their act, their behavior and performances. And this can be very much used, this kind of technique can be very much used to reduce the conflicts and also improving the interpersonal skills. So these are common learning outcomes when we see about the role plays. And in very simple words, if we say, it actually decreases the gap between thinking and doing, because here we are actually doing what we are what our learning outcome is, what we are planning to deliver, that we are actually doing. So this is a like role plays. There is one big disadvantage with role plays is that many a time it goes completely bizarre, or many a times people get carried away in the role plays also. Today we have a time restriction, so हमने 2-3 minute का ही अपना discussion रखा था. But in actual practice, when we do role plays, I mean, most of you would have experienced that many a time अगर उसको ठीक से channelize नहीं करते हैं, then it goes in totally a different direction. So these are some common steps which we can take up to make the role plays very much to the point, as well as to get the desired outcome which we have planned out of this role plays. So most important thing in role plays becomes explaining the expectations and explaining what we are targeting to get out of that role play, why we are doing this thing. Explaining this thing to the audience is most important. Because many a times it is taken as fun element also. Sometimes they do it, the people are not completely ready to do the role plays. They either not understand the role, or they just do it for the sake of doing. और अगर वैसे करते हैं तो the desired outcome is not met. So as a facilitator, it is very important to explain the purpose and the overall outline of the skills which we are talking about, which are supposed to be demonstrated over there. Whenever we are selecting the participants, it is very important to make them familiar with this idea. Like in today's case, in the starting itself, I told this is not the best way to start a role play, but since we just had to introduce that topic, so we did like this. Otherwise, what it is done, we have to give them in prior. What do you have to do? What is your role? What is expected out of this role? So the participants has to be completely clear on what is the expectations, and if he has any queries, he can place there. So encourage them to participate in the role. And equally important is the role of the observers over there. Here, everybody of us are observers. And in the ideal situation, when we can set up some list of observers. At the same time, we can have all the audience also as open to give their feedbacks. And time management is most important over here. So we need to be always on that allotted time frame, keeping the time frame in the mind. And towards the end of this program, the most important part goes about the debriefing exercise. about the discussions or on what have we learned or what exactly are the findings of the role play, the observations from everybody. This all needs to be in a proper what we say as a proper step-by-step procedure. So Dr. Indu, you would like to add something over here?
No, I think you have explained these steps very well, that how do you really go about the organizing a role play, and plus they will get to see a lot of role plays when we will do it in the future sessions. Almost in every session we will have role play, and you will be able to observe these role steps, in a very subtle manner that will be automatically integrated with the role play. So that's a good slide, I think. Yeah, go ahead, please. Yeah.
Right. So advantages, as we have discussed step by step, it is very engaging. Like, if you are into a role play, you are into a role play. So the person who is there, they would be involved in that. And again, learning by doing is something which is, it's a part of the adult learning principle. So we have a long lasting impact when we learn something while doing that. And yes, it's a way to improve the behavior, because again, if we go back to the understanding, it gives a reflection about how you are doing actually. So it helps in self awareness, it helps in empathizing with others, and at the same time it actually provides us to learn by mistake, because we are doing that thing. We will be understanding what we are doing. So even if we are doing a role to perfection, we would be knowing that where we are lacking. So if there is a conscious effort made, then it will definitely help out. Disadvantages, yes, there are many of the people, they don't choose role plays. The reason is because there are some disadvantages associated with that. Sometimes it lacks the seriousness and the reality. Even among the participants, many of the participants they are there, but they are actually not performing it. So the activity, the overall, if they are not willing to perform, in that case the overall activity gets defeated.
Yeah.
And sometimes, as Dr. Gaurang has very rightly told, that this could have been done in different manners. So the complexities which are actually there at work. So many a times in a simple role play techniques, because role plays, if you make it multiple levels, in that case what will happen is, like, it may get into too many directions. And if you want to keep it simple, the complexity part gets compromised. So this is a kind of a challenge which is there. But still, if moderated properly, this can be done in separate ways. Then it even when it looks so simple, many a times it loses the credibility also. And yes, the need to have a good and a trained facilitator while doing this is a must. So this is common disadvantages and probable solutions also. We can come up to the do's and don'ts. Any idea anybody would like to share something on that? Common do's and don'ts. What do you think in the role plays?
Pooja, I think you can go ahead with the presentation, because it's already 15 minutes over the time. So we need to really...
Okay. Yeah, just 1 second. Yes, so the common do's, if we say, planning plays the most important part while we are doing the role plays. There is no substitute, there is no alternative for that. Planning indeed is the most important part over there. The scenarios needs to be properly, whatever training or whatever message or whatever learning you want to impart, that entire scenario must be properly covered in the role play, the case study that you're doing. It is mandatory to give enough time for preparation and post-program discussions, both of the things, early in the starting also, towards the end also, because the person needs to understand what they are. So have a basic idea about what the role and post-program discussions. Ground rules for the programs, for the entire setup, must be set very strongly. And there has to be a complete watch on time, because it may easily go out of your hand when the role plays are going on. And expectation settings in the starting is mandatory, as in if we want to do this role play for conflict management, or we want to say some situation wherein we have to get different perspectives about this. So in the starting itself, we can very easily just mention this thing very clearly, that the outcome we are expecting is to get different viewpoints about this, or we are trying to sort out the conflict which has arisen between two departments. So something like this, but the expectations out of this this entire role play must be clearly outlined in the starting. And yes, after the role play is completed, there is again a very important part that we have to involve the participants to share their ideas, which can help to make the situation better, or different ideas which can be can be the alternatives for the ones which are there. And again, as in this discussion also, we have seen this thing during the debriefing, or when we are discussing about the observations, it is always good to refer to the characters particularly, or their characters action, without referring to the individuals. So many a time in role play, because we know the individual first and then the character, so we start talking like, no, he did like this, or he should did like this. So here also we have seen the same thing. So it's always good, or it always recommended that to refer to the characters rather than the individuals. Like in our today's discussion, the doctor who was referring or was suggesting the patient or the patient's relative, like this. So Dr. Ila and Dr. Deepthi were playing those roles, but at the same time, the roles were these. And whenever we are going to give the feedbacks about this, it's always good to start with the positive first and then talk about the areas of improvement. The common do's when we are going to do the role plays. About the don'ts, which are not required, or we can be avoided in the role plays. As a facilitator, never interfere when the role play is in progress, because then the natural the flow which is coming, or the way the characters are developing over there, their communication, their thinking process, that gets a bit altered. So there is it's not good to interfere when the role play is in progress. And as in the previous discussion also, I told, like, it is always advisable not to focus on too many learnings in a single role play. It's always good to keep it simple, so that the participants are also focused and the discussion also remains focused. And even in a role play also, it's always good to let the participants or let the characters find out a solution. Let them discuss within themselves, because they are the ones who are actually playing that role. So give them some time, let them do that entire discussions on their own, of course keeping the time in the mind, and never jump on to for rescuing or suggesting or prompting something during a role play. Of course, none of the people who will be doing the role plays might not be the good actors. So never make fun of the people who are doing the role plays over there. This is like from a facilitator's perspective. If tomorrow in our setup we are going to use this role play as a technique, so this is something from our side, like this would be good if we go by this, it would be bad if we do these don'ts over there as a facilitator. Now, like any other pedagogy or any other the teaching methodologies, it is always good to have the evaluation, how to evaluate, and how does the role play gets evaluated. How do you know the entire exercise that you have done is making useful? So evaluation is again important over there. How do we get that? We get that from the feedbacks from the participants and the observers. Because we'll be, obviously when we are discussing a situation in mind, there would be certain set answers for that. There were certain the ways how that situation can be tackled. So the feedbacks from the participants, the suggestions from the observers, any clues that would be there to improve that particular conversation, that will all be the kind of feedback, the feedbacks or the evaluation tools that you will be getting out of that. And yes, the information regarding the specific learnings from the session, this is a must. Like towards the end of the role play, when we have completed that thing, it is always good to have a discussion on specific learnings that the participants as well as the observers had from that role play. So overall, this is a very gist of the role plays that I've tried to gather over there. Thank you, Dr. Indu, for the guidance in there. So we are open for discussions, and suggestions also.
Thank you, Pooja. If you may stop sharing the screen.
Yeah, I'll do that. Yep.
So thank you for a wonderful presentation, very detailed one. I think you really covered all aspects of role plays, and role plays we are going to use extensively in the program, so you will get to see more of it. And one thing that I would like to emphasize on is please time your presentation. Any idea, Pooja, how much time did you take for this presentation?
I exceeded by full 15 minutes.
No, you have total taken 40 minutes.
Okay.
So the thing is, it's okay. I understand. See, timing is very important. You have to just give them the gist. The idea is show the pedagogy that you want to talk about. Take a minute and talk about advantages. Take a minute, talk about disadvantages, do's, don'ts, and where do you apply. For rest others, I'm requesting that please stick to the timeline, because otherwise you will be going beyond time. For me, it is day. I'm okay. But for you all, today we had one presentation. If we had two, then it would have been, 11 o'clock. So that's not possible. So please stick to the timeline and keep it very simple. And you don't have to read the whole thing. See, again, PPT is not a good way of conducting a discussion. PPT is just to keep us on track. And what we have to see, and you should always have a watch right in front of you, a clock in front of you, so that you can time your presentation. That's very, very important. With this, I think I'll just end it here. I have put the feedback form in the chat box. So quickly, if you could give the feedback, not for the presentation, but it is for this session, because I'm not asking you to evaluate the presentation. So quickly, if you may all give your feedback for the topic of understanding patients' expectations.
Pooja, you can share your PPT if it is okay with you later.
Certainly, ma'am, I'll do that.
Yeah, you can put it in the group. Everybody can see.
Yeah, I'll do that.
Sure.